Okay. A very good morning to you all. I'm Dr. Swati, and we welcome you all here in our instruction course titled How to Avoid Being a Victim of Glaucoma Overdiagnosis Syndrome. And at the outset, I would like to thank AIOS for this opportunity. And as we all know that glaucoma is an optic neuropathy, which is the most common culprit of irreversible loss of vision. However, there are many masquerades and technical defects which may be mistaken for glaucoma, and the patient is started on medication which are not required. And on the other hand, the patient may be having glaucoma which is not diagnosed. For the clinician, the pressure of not missing glaucoma is huge, and there is a fear of litigation. Dealing with over-aware, Google-savvy patients may affect the clinician's judgment and lead to an overdiagnosis or underdiagnosis of glaucoma. So, the first speaker in our IC is Dr. S.S. Pandav, sir, and sir doesn't need any introduction. And he is the past president of Glaucoma Society of India, and currently he is heading the ophthalmology department, PGI Chandigarh. Over to you, sir.
Thank you, Swati, for including me to your instruction course. So basically, the question is in the glaucoma diagnosis, is the disc glaucomatous? I mean, this question actually arises every time you look at the glaucoma patient. You will look at the optic disc, and the first question comes to your mind is this glaucoma or not? And that's a very relevant and the most important clinical question actually when we are dealing with glaucoma patients. So we'll be kind of it's not moving. Can you move the slide? Okay, so the optic disc evaluation is very important from glaucoma diagnosis point of view, and this is very critical and very often is the first site to detect glaucoma. If you look at all the patients who have been detected glaucoma, I think 2/3 of them get picked up or detected because someone looked at the optic nerve head. And if you're depending only on intraocular pressure, one reading, you'll miss 2/3 of them. So diagnostic rate is only about 30%, and if you're doing repeated IOPs, then also it will go up to about 50% and not more than that. So IOP is not a good way to detect glaucoma. Optic disc evaluation is a better way to detect glaucoma. That's number one. So is this disc glaucomatous? So the question remains. So this is a patient coming to you, 45-year-old male patient, and what do you think, audience? So how many of you think that this is glaucoma? Raise your hands. And how many of you think this is not glaucoma? Okay, so some are for glaucoma, others for not glaucoma. Remaining are kind of a doubtful, right? And this happens many times because it's not always that you can make up your mind in the first go. And if that happens, then how do we deal with that situation? So that's what I think we are basically going to discuss here. So if you're not able to make up your mind, then the best thing to do is to kind of assign some kind of probability. So, okay, this is the disc. What is the probability of it as being glaucomatous? Is very low or very high? So on the right side of the spectrum, the two ends of the spectrum are easy to identify. So if it's a normal disc, you could easily say, okay, this is normal. And if it's obviously got glaucomatous, it's again easy to say, okay, this is glaucomatous. But in between, if there's like the discs I showed you, they're somewhere in between. And those discs, clinical, we call them glaucoma suspects. But saying them glaucoma suspect is not enough because this doesn't give you what to do, because in between there are many varieties of the discs are there and which could be glaucoma suspects. So idea is basically to identify glaucoma as early as possible. So our strategy would be that if you have a glaucoma suspect, try to dissect that further. So give a little more probability to that or split that probability a little more. Is it likely glaucoma, or it is possible glaucoma, or it's unlikely glaucoma? Now, if a glaucoma suspect, you can split in these categories. This will help you make a decision. So if you think, okay, the disc is not exactly normal, but it's unlikely to be glaucoma, so that means you will not do anything to that patient. You'll just observe or tell him, you won't treat or investigate. But if your impression is probability is like possible glaucoma or likely glaucoma, if it's a likely glaucoma, you can straightforward, go with an investigation and maybe even start treatment. And if it's a possible glaucoma, you will at least investigate the patient. So this kind of risk stratification, the probability assignment to a given disc would help you take a clinical decision that what is the next step that you would like to do. There are many ways of looking at the optic nerve head, and you have all read in your books. There are classical signs given by Amle. That there are 7, 8 discs of features are there, shape, size, cup, and so on. There are some other methods of looking at, like you have slide, Seegeek slide, or force series of slide, where they talk about the 5 R's of glaucoma, and you have a disc damage likelihood score, which gives a little more objective way of looking at the disc cup and neuroretinal rim. My approach is a little bit simple. What I do is I look at what is important. So a lot of these disc signs feature in the disc, they are important in a way, but they are not the most important, and many of them are actually just there because glaucoma happened or did not happen, but those things are there, like blood vessels change in certain way. So change in the blood vessel configuration doesn't say that is glaucoma, it just reflects effect of glaucoma on the disc vessels, and that actually gives you some kind of indirectly a clue that this patient might be having glaucoma. So those are just clues. So what is important in the optic nerve head basically is there are only 2 things. There's only one thing basically, that's a neural tissue. So what we are concerned in glaucoma is neural tissue, because glaucoma is an optic neuropathy, and you see loss of neural tissue in glaucoma patients. So focus on the neural tissue, and the neural tissue in eye is neuroretinal rim and the nerve fiber layer. So these are the 2 elements which are neural tissues. So mentally you need to dissect the neural rim and the nerve fiber layer. So if you can mentally dissect, so if you look at the eye for glaucoma, mentally you dissect where is the neural rim tissue, and once you have isolated the rim tissue mentally, visually, you have to ask a couple of questions. So is the amount adequate? Is there a neural tissue that you can identify and is good enough or enough, which is normally you would see? Is it rightly distributed? There's a certain kind of proper distribution in the optic nerve head, of the neural tissue is for following the proper distribution. And is it healthy, or does it look sick, or any evidence that is a disease in neural rim tissue? So rim tissue may be there, but it may not be healthy. So you will have to basically ask these 3 questions to yourself, and then look at the nerve fiber layer, and is it there or there is any loss? So if the answer is if that is adequate, if the answer is yes, then there's no glaucoma. Basically you are dealing with this eye is normal. But if answer to any of this is no, then you have to consider the probability, whether it's strongly in favor of glaucoma or somewhere in between. The problem is that there's a lot of normal variability in glaucoma, and you can be, there'll be a lot of confounders. So that's why glaucoma diagnosis doesn't come that easy, because there are certain confounders. Now in these 3 discs, they all look very different. So this one looks very different, this one is different, this one is different. So which one you think is glaucomatous? So again, the important thing here to consider is defining the neural rim tissue. So first thing is to define the tissue. So here you can define the tissue. On temporal side it's a little hard, but you can see some tissue there. You can very easily define the tissue. So once you have defined the neuroretinal rim, now there's no confusion here. Now you can see there's a good amount of rim tissue is present, all eyes is properly distributed, and there's no evidence of any disease. So all these eyes are normal, right? So other thing is how that is distributed, and ISNT rule you are all familiar with, so I'll not spend much time on this, but there's a kind of inferior, superior, nasal, and temporal. So that's how it is distributed. So look at the optic nerve head now from the distribution point of view. Now these are the 3 discs. What do you think about the distribution and the amount of tissue here? So you can see the neuroretinal rim is there. There's good amount is there. A lot of rim tissue is there. So there's a good amount of rim tissue that you can actually identify, but is it distributed properly? So if you, again, the exercise is to define the limits. So the key skills that you need to diagnose glaucoma is 2 only. That's you should be able to define the inner edge of the scleral canal, and you should be able to define the inner limit of the neural rim. So if you can do these things reliably, then your glaucoma diagnosis becomes easier. So you can see, if you define them here, you can see the rim tissue is actually missing at certain areas. So that gives you a clue that this is a problem. There's a loss of rim tissue basically, and loss of rim tissue would mean that there's a neuropathy there. And then again, you could have confounders here also, because if the eye is normal, then this IC90 rule is applicable. But if the the disc is tilted, or if it is rotated, then IC90 rule may not be applicable. So that you have to keep in mind. And other problem comes when the as you can see, the inferior rim is actually behaving like a temporal rim here, but this is because of the disc tilt. And then of course you have to look at the if the cup is shallow or deep. So if the cup is very shallow, then again you might have a little difficulty in defining the inner limit of the rim tissue, and there again you can make a mistake. Is the neural tissue healthy? So I think again, obviously you can see this is a pale disc, so it may not be glaucoma, but this is not a healthy disc. So but this is rim tissue is there. So here again you can see there's something is not right with the tissue here, and you also have some atrophy in the peripapillary area. So there's a rim change there, and so this is again probably a resolving hemorrhage as well. There's a disc hemorrhage clearly here, so there's a sign of that this is not healthy. Sometimes you can have extensive peripapillary atrophy, which again suggests that something is going on in the posterior segment, but it is not always glaucoma. So if this is interesting, that if there's a lot of peripapillary atrophy here, but if you define the rim tissue here, you can see the rim is very well defined, and there's no problem with the rim itself. So this is again a healthy eye. So this is basically how you would be looking at the optic nerves. Can you just give me a little more slides? So I'll make it a little quickly. Yeah. All right. So and the third thing I said is the neural the nerve fiber layer, which you have to see. So if you see a nerve fiber layer like this, again there's indicate that there's a problem with the neural tissue there. So there's a loss of tissue there, and this is how this would look like. So you can see that the rim area is very well defined. There's a little thinning. IC90 rule is not followed here, but and also there's a tissue. So if you see this kind of a picture, there's no doubt that this eye has glaucoma. So glaucoma or not? So what is your question? So is this has glaucoma? So obviously all the parameters we have spoken are actually normal here. So this is not glaucoma. So but again you have to take a final call whether that this is glaucomatous or not. So this is glaucoma or not is the same eye. So if you can't define what is the probability, so probability is unlikely. There is little change in this here, which might be tempted to say, oh, there's a little notch there, but there's no other evidence in the nerve fiber or anywhere else to say that it's glaucoma. So there's a little suspicion, but it's not really enough to say this is glaucoma. So you can probably say it's unlikely glaucoma. So if it's unlikely glaucoma, you will just follow up this patient, after 1 year or so. So this is glaucoma or not? Again, the question, what would you say? Where will you place it? Normal, unlikely, possible, likely. So again, if you define the disc margins, we did the OCT, we did HRT, everything is normal. Family history of glaucoma is there. Now, based on this, there's a possibility of glaucoma because there's a little change over there. And we did the visual field because we was considering the possible glaucoma. So we did the visual field, a little change there. And when you put everything together, the diagnosis actually moves towards likely glaucoma, because now you have a little thinning of the nerve fiber rim there. There's a little bit of thinning of the nerve fiber layer here and here as well. So once you look at more carefully, the signs, they actually start coming out, and this is a likely patient of glaucoma. This quickly is glaucoma or not? So again, there's a hemorrhage there. If you notice that there's a nerve fiber defect, and there's you don't even need a visual field or any other investigation to say that this is a glaucoma patient. So this is almost certainly a glaucoma patient. Glaucoma or not glaucoma? So again, you can see there's a bit of thinning there. There's a hemorrhage there, thinning there, hemorrhage, and there's a nerve fiber thinning there. So if you can see these signs, definitely you have this is a likely glaucoma patients again. So this is again a normal glaucoma patient. So this is normal. So that way you can actually ratify your, so again there's a little change, but not enough basically. So it's unlikely glaucoma patients. On the other hand, this eye, what do you think about this eye? It's a good neural retinal rim. There's a little bit of, you can see there's a little bit of notch there, not very clear, but there is something there. And this nerve fiber layer looks a little thinner. That it's not coming as good in the projection, but still you can make out that a little bit of darkening is happening there. And if you draw the limits of the disc and the neural rim, it stands out, and it stands out there. and this becomes likely glaucoma. And when you do visual field for this patient, there's a there's a visual field defect as well. So I think these are very subtle signs, but if you look at your disc more carefully, you can actually pick up, and you can pick up glaucoma before it appears on the OCT or before it even appears in the visual fields. So I think that is the message. So glaucoma diagnosis is a clinical skill. Disc evaluation is fundamental, is very important, and often this is the first place to detect a glaucoma disc change. Thank you very much.
So, my topic is all that glitters is not gold and errors in visual field interpretation. So as we all know that glaucoma is a progressive optic neuropathy with characteristic optic nerve head changes and retinal nerve fiber layer damage with visual field defects, and the intraocular pressure is actually a risk factor which may or may not be raised. The problem in our country is that glaucoma is underdiagnosed and overtreated. The reason is poor access to healthcare facilities, poverty, lack of public awareness, and lack of equipments and infrastructure. On the other hand, the over treatment is because of fear of missing glaucoma among the clinicians, the fear of losing a patient, or the fear of the patient losing sight and litigation, then starting treatment on a single intraocular pressure reading and over-reliance on investigations. And improper training and lack of experience is common to both of them. So visual field tests, they are the gold standard for diagnosing glaucoma, and they play a crucial role in assessing the progression of the disease. What are the glaucomatous visual field defects? Actually, they follow the arrangement of the axons of the retinal nerve fiber layer. So there are this pointer. Okay. So as you see, the nerve fiber layer, the axons are arranged in a particular manner. This papillomacular bundle, which is straight and comes from macula to the disc, while the superior and inferior arcuate bundles, they arch above these fibers and reach the superior and inferior poles of the disc. These fibers are said to be the most vulnerable fibers for glaucoma. And on the other hand, on the nasal side, we have the radial or fan-shaped fibers. So what are the perimetric dilemmas? We can have scenarios where the visual field defect is present, but there is no pathology. When the visual field defect is present, but it is not a glaucomatous pathology. And thirdly, the field defect is absent, but there is glaucoma. So the first, the visual field defect is present, but there is no pathology. The reasons are that the test is not explained to the patient properly, incorrect data entry is done, and there is a learning curve from the patient side, very small or very large pupils. Then there are artifacts and technical issues, and the patient cannot do the test. There are certain patients who cannot do the test at all, no matter what you do and how you explain. So coming to this patient, this 67-year-old lady, she was diagnosed as glaucoma elsewhere, and she was started on one anti-glaucoma medication. But on examination, we found that the visual field showed a superior arcuate defect in the right eye, and the left eye was showing edge defect. So looking at the facial features of the patient, one can see that the hooded eyelids, they can cause these lid artifacts. And we did a lid taping and repeated the test, and now the tests are looking normal. So the pressures were normal, so we did not treat the patient, and there was no need to treat. Now, the second is the lens rim artifact, which are because of the incorrect placement of the trial lens. So the lens is either too far from where it should be placed. It is placed too far from the eye, and you get these edge defects, which are dense peripheral defects with sharp demarcation. And the reason is either a very high-powered lens or hyperopic patients. And when there are two lenses, or it can give an impression of peripheral constriction or a arcuate scotoma. Now, this is a classical example of an inattentive patient with high false negatives. The reason is that the patient, after doing the first four points, the patient went to sleep probably and did not complete the test properly. So that is why we get high false negatives. However, high false negatives can also be there when the patient is having an advanced disease. Uh, this this is a classical example of a trigger happy patient or over attentive patient. You can see that the visual field on the left side is practically, there is no grayscale left, and all the points are having very abnormally high sensitivity for the age. And if you look at the total deviation plot, is looking perfectly normal, but the pattern deviation plot is showing a scotoma. We call it a pseudo scotoma, and this is because of the abnormal high sensitivity of the remaining points, that the normal points, they appear as scotomatous. So, the second type of defect is when field defect is present, but the pathology is non-glaucomatous. This is first case. This is a 75-year-old female with a normal intraocular pressure and without medication. And we found that there was a visual field defect in the left eye, including this in total inferior altitudinal field was gone with encroachment into the superior half also. So when we look at the OCT, the right eye picture is normal, but the left eye is totally anomalous. And if you look at the clinical picture, the fundus photo, the right eye disc is normal, but the left eye is showing this is optic disc coloboma. And the defect is stable in these patients mostly, and we do not need to treat them unless the pressure is going on the higher side. So similarly, this second case, here you can see there are arcuate defects in both the eyes, superior in the right eye and inferior arcuate defect in the left eye. And but if you look closely, there is the blind spot is missing here. You cannot see a proper blind spot here in both the eyes. And when we look at the other things, the disc size was very small, 1.06 and 0.94 millimeters square. There was severe thinning of the retinal nerve fiber layer. And the clinical picture, you can see there is this double ring sign, which is classical for, this is basically optic nerve hypoplasia patient. So the third case here, sorry. So this patient, she's having a pallor of the optic disc in both the eyes. In one eye, it is the superior pallor in the right eye, while in the left eye, you can see the inferior pallor. And the OCT is also showing corresponding picture. When we do the visual field test, we get this kind of pattern. So the pressures were normal, but this patient was having bilateral NAION, non-ischemic, non-arthritic ischemic optic neuropathy in both the eyes. So another case of patient with large optic disc, you can see the right eye disc is large, the cup is around 0.6:1, but the left eye disc is anomalous in shape. And here you can see that there is inferior crescent or conus kind of thing, and there is a tilt of the optic nerve, which is seen here in the OCT picture also, although the parameters are grossly normal. So when we do the visual field test, the right eye picture is okay, but the left eye you can see an enlargement of blind spot and defects on the adjacent to the blind spot and in the superior field, which is corresponding to the optic nerve anomalous area. So this is the fifth case where you can see a paracentral defect, a defect close to the fixation point in this right eye visual field. So when we do the OCT, it is showing GCC changes in the right eye, and the clinical picture of the left eye is okay, but the right eye, this patient had a history of trauma, blunt trauma, and you can notice this pallor in the right eye, and he had a subretinal fluid and followed by macular scarring in the right eye. This is the reason for this visual field defect in the paracentral area, and it is not glaucoma. Then this is a patient, 58-year-old male, who was started on dorzolamide and timolol combination in both the eyes elsewhere. The baseline IOP and visual fields were not available or not done. BCVA was 6/6 and 6/36, and he was noted as amblyopia in left eye. So when we do the visual field test, when the patient enters the examination room, actually I saw a scar on the forehead on the left side, and there was RAPD in the left eye. Disc was 0.7 and 0.4 with marked pallor, and on probing, the patient gave a history of a road traffic accident in 2007, and this was followed by a rapid loss of vision in the left eye along with a hearing loss. Neurosurgery was done, and there was a craniotomy scar on the left side. So in the visual field, you can see there is a quadrantopia. So right side superior quadrantopia with left side central scotoma actually. So this is the superior quadrant that is involved in the patient, and this left eye is the central scotoma is also present. So we stopped the anti-glaucoma medication and called the patient in 2 weeks with an MRI report. Now, the neurological field defects should not be missed because they follow the vertical meridian, and this patient is another case of neurological disease when he presented to us with the field loss on the left side for 3 days only, and the patient was pseudophakic with a vision of 6/6 in both eyes. Pressures were normal, but the field tests are showing clearly that this is a homonymous hemianopia. The left-sided homonymous hemianopia along with a macular sparing. So we sent the patient for a neurological assessment. The neurological part will be covered by Dr. Sumit Monga, so I'm not going in detail for these patients. So this is another example of optic nerve, non-glaucomatous optic neuropathy patient who had central scotoma in both the eyes. Then there can be overlaps also. Like this patient was having tilted disc anomaly with stable visual field defects for years, but the patient is on anti-glaucoma medications as the pressures were in 30s. On gonioscopy, we found that there was primary angle closure glaucoma also, so we continued the medication. This is the there is another masquerade, that is the lasered retina. When retina has been lasered previously, you can find arcuate scars or even peripheral scars of post panretinal photocoagulation. So, excuse me. And whenever you are dealing with a patient who is having this kind of visual field defect, when there is total loss in one eye and the other eye is grossly normal, one should carefully examine this patient and not take it as glaucoma at the first visit. So the third part is no field defect is present, but glaucoma is diagnosed. This is seen mainly in optic, OST and pre-perimetric glaucoma, but there can be a misdiagnosis also. So do not ignore this single paracentral or nasal depressed point, which was there in this patient here in the pattern deviation. But the patient was not started on glaucoma medicine. And when the patient came back after 9 months, you see this defect has increased in size, and there is some nasal step also. So 10-2 is mandatory even for a single depressed point in the central area. So to summarize, a meticulous workup and documentation is needed. Reliable fields and reproducible visual field effects should be there. And unilateral advanced field loss should always ring a bell. And central vision is spared in glaucoma till late stages. If the patient has lost vision, so especially in one eye, one should deal with the patient with caution. Then multiple diseases can coexist and produce visual field defects, and there are overlaps and gray zones. Then one can make use of the diurnal variation or neuroimaging tests wherever they are needed. Thank you very much.
Thank you, Dr. Swati. Any questions to Dr. Swati? I think visual field is again very important, because any field defect is not a glaucoma. So many times happen that you are screening for glaucoma, and if the visual field defect comes, then the tendency is to label that patient as glaucoma. But I think Dr. Swati has very nicely told there are many other situations which can produce visual field defect, which can be confused with glaucoma patients. So it's always better to look at the total picture. So look at the visual field defect, whether this conforms to glaucoma or does it conform to any other known entity. Is a central scotoma, it's a altitudinal defect, or it's a vertically like hemianopic kind of a pattern. So that actually gives you a some idea whether this is glaucomatous or not. And also other diseases you have to keep in mind that a laser has been done, or there's a CRV or VRVO particularly, they can produce a pattern which is similar to glaucoma. So I think again you have to go back to the patient, look at the fundus and see if there's any of those conditions exist before you label that patient as glaucoma or the visual field defect as glaucomatous. Thank you, Dr. Swati. I think you can invite the next person now.
So the next speaker is Dr. Suman. She's a cataract and glaucoma consultant, Center for Sight, Delhi.
Good afternoon, ladies and gentlemen. I would like to thank AIOS and Dr. Swati for having me here. Today I am going to speak on decoding the color coding on OCT. As we all know, structural damage precedes functional loss, and even in mild glaucoma, approximately 50% of the ganglion cells are already lost before apparent on visual fields. And all we know that visual fields are not always reliable and reproducible. So OCT is the important tool to diagnose and to monitor progression in perimetric glaucoma. There are 3 standard scanning protocols that are used for glaucoma diagnosis: circumperipapillary retinal nerve fiber layer scan, optic nerve head scan, and macular scan. This is OptoView scan, where we get RNFL index values, ONH, GCC, TSNIT map, symmetry analysis, RFNL thickness map, and GCC map. So before reading OCT, don't get fooled by red and green areas. False red and false green results are fairly common due to artifacts. So what is red disease? A diagnosis of glaucoma is made based on mistaken identification of an area as abnormal. These commonly occur in patients who are not represented on normative database, and RFNL thickness falls outside the normal range and depicted in red color, which can occur in non-glaucomatous eyes too, and in extreme refractive states, especially in high myopia. And what is green disease? A glaucoma diagnosis is missed as OCT appears normal. Here on this fundus photograph, you can see there is a wedge defect. There is a wedge defect, but the OCT is normal because the instrument averages the thickness in a particular sector. Again, on this fundus photo, you can see the wedge defect, but the OCT is green color because the focal change is masked by the global parameters. Look for the artifacts and anatomical variations. These may occur in 1/3 of the cases. Scan quality affects the OCT performance. If the signal strength is poor, you have to figure out the cause. It might be because of cataract, any media opacity, corneal edema, vitreous floater, or dry eye. And also look for the technical errors, might be because of discentration, blinks, and eye movements. Pupil dilatation does not affect the signal strength, RNFL measurement, or reproducibility in normal eyes. Minimum pupil diameter requirement is 2 mm for OCT measurements. On serous OCT, signal strength should be 6 or more than 6, and on OptoView, it should be 40 or more than 40. This is an OptoView scan where you can see in the left eye there is FLV and GLV loss, and on this GCC map you see the red area here. But in the same patient at the same time, when we repeated the scan, everything came to normal, and this was because of this blinking artifact. Again, you see here the red black dot here, and sometimes during the acquisition of the scan, patient blinks the eye and this type of black horizontal line can be seen. So in these types of patients, machine is missing the data, so it can be flagged as red. So this is because of vitreous floater and blinking artifact, and you should repeat the scan and look for these type of artifacts. Again, there can be a centration artifact. If you see the breakage in the blood vessels, this is because of motion artifact, and these black horizontal lines, these are all blinking artifacts. Scan alignment is very important. A well-focused scan where the entire RFNL is in the scan area. And the next is the defocus scan. Here this is the serous OCT where this black area is the artifact, and on this, when you see at this RNFL thickness map, the thickness is going down to 0, which is not possible. So when we looked at this horizontal and vertical tomograms, you see that this is not well focused, this is defocused. So this is flagged as red. So in these cases, we should repeat the scan again. Again, this is OptoView. In the left eye is the registration artifact. There are other factors that can affect the OCT parameters like age, optic nerve head variation like tilted, small, large disc, axial length, high refractive error, and blood vessel position. All OCT normative data is age related. This is serous OCT scan of a less than 18 years of patient where the normative data is not available for comparison. So date of birth is very important when you take the scan. Optic disc size, larger discs have thicker RNFL measurements. Since the 3.4 mm measurement circle is fixed, so when the RNFL goes out of the optic nerve, it is thicker, and when it fans out, it becomes thinner. So in the large disc, it measures the thicker RNFL. So larger disc, they must suffer more damage before resisting as abnormal on OCT, and they have lower sensitivity for early glaucoma detection. And mild glaucoma is most easily detected in patients with small optic nerve head, but these discs are associated with false positive results too. Axial length, the longer the eye, thinner the mean RNFL. With every 1 mm increase in axial length, 2.2 micron meter decrease in RNFL thickness occurs. So there are high risk of OCT false positive results. Look at this example. Here the disc is okay, but and the RNFL thickness is quite good, but the RNFL bundles are converging temporally here. RNFL bundles are converging temporally instead of going like this. So the machine is measuring this area as a deviation, which is an anatomical variation, not a glaucomatous condition. So this is known as the lateral RNFL shift, which is seen in high myopic patients. In cases of large peripapillary atrophy with posterior staphyloma, erroneous results can occur due to inability of the measurement circle to stretch beyond this large peripapillary area, and it can cause the segmentation error and cause the red disease. Blood vessel positions. In the RNFL bundles fall on major blood vessels, so variation in the blood vessel position can cause variation in RNFL profiles. So if you see at this example, this this area, do you think this is a real defect? When you, and also at this RNFL thickness map, this double hump pattern is lost and the RNFL thickness is going down. When you look at this fundus picture, two RNFL bundles are going into one optic nerve and instead of one. So this is known as split RNFL bundle. Here you can see this black area where the machine is missing the data, and you can see this floor effect, which is again not possible. So we asked the patient to move the eye and again repeated the scan, and everything came to normal. This was because of this V's ring. Here again you can see the lot of red areas and the elevations on instead of cupping on this vertical and horizontal tomogram. And visual field effects are also there. When we look at the fundus photo, you can see the hyper-reflective bodies. This is optic nerve head drusen. These patients are very difficult to diagnose. And another example, here you can see the hyper-reflectivity and the thickness is very high. And the shadowing effect, this is because of this medullary nerve fiber layer, which can cause false green disease. Again, sometimes during OCT some OCT part is blocked by the iris in cases of poor pupil dilatation. So it can cause the this red disease, this and cause the incomplete segmentation artifact. So these type of patients, scan should be repeated after dilatation of the pupil. There are other ocular anomalies like ERM, vitreoretinal tractions, V's ring, peripapillary retinoschisis, and uveitis that can cause artifactual increase in RFNL thickness and cause the false green disease. Look at this example here. The cupping is there, but in the left eye, the thickness is going 137, and here this is going high in the sky, which is very high. This is because of this. When we looked at this scan, macular scan, because of this cystoid macular edema. Again, this is an example where in the right eye, if you see the lot of RNFL thinning is there, but the cup volume is 0. And the visual fields inferior quadrantopia, and when we looked at the disc photo, this is a case of post-papilledema optic atrophy. This was again a case of superior half is lost here and inferior altitudinal defect in the right eye. But when we looked at this macular photo, the superior neurosensory retina is lost above the fovea, and this right eye fundus photo, this disc is pale. This was a case of non-arthritic ischemic neuropathy. So, and the OCT has no role in advanced glaucoma cases because of this floor effect, because the RNFL thickness rarely falls below 50 micron and almost never below 40 micron due to the assumed presence of residual glial or non-neural tissue, including blood vessels. So, in nutshell, these operator-dependent, machine-dependent, and patient-dependent factors can alter your scan, and you should look into all these things. And take-home message is that acquire a scan with proper protocol, look for artifacts and anatomical variations, pay attention to all maps on the OCT. If any discrepancy with the clinical picture, repeat the scan. Careful correlation of RNFL and GCC with clinical picture and perimetry reduces the erroneous results. Thank you.
Good afternoon, everybody. I'm Dr. Surbhi Taneja. I would like to thank AIOS for this opportunity and to everyone for being here. Today I'll be discussing tonometry and the inaccuracies associated with the gold standard. As glaucoma specialist, I'm sure we do take intraocular pressure day in and day out. It is the fundamental parameter of ocular health and disease. IOP measurement not only helps in the diagnosis and management of glaucoma, but also in the management of the corneal, lenticular, and VR diseases. Tonometry refers to the measurement of the IOP. EMGT says that the IOP reduction by 1 mmHg, it reduces the risk of the progressive nerve damage by 10%. Therefore, it is very important to measure the IOP accurately for the early diagnosis of the glaucoma and also for the follow-up of these patients. So what is an ideal tonometer? It is the one which gives accurate and reasonable IOP measurement, is convenient to use, is simple to calibrate, it's stable and easier to standardize and free of maintenance problems. So over the years, many tonometers have been devised, and currently it is the Goldman tonometer, which is the gold standard. But it is not fail-proof. It has its accuracy is influenced by multiple factors, which we will be going into detail about. So overall, there have been many tonometers such as indentation, applanation, and rebound tonometers. Contour tonometer is there, and recently there have also been these NCT non-contact type tonometers as well. So a little bit about the corneal biomechanics, which is very important because it affects the cornea's functional capability and also impacts vision and as well as the IOP measurement. So certain factors which or the properties that make up the corneal biomechanics is the central corneal thickness, and there is corneal hysteresis, which is the measure of the viscoelasticity of cornea. Decreased CH has been associated with glaucoma. Another is the corneal resistance factor, which again is a measure of the ocular rigidity. The applanation tonometer, which is most commonly used, is based on the Embed-Fick law, and it states that its main requirement is that it should be that the IOP is taken in a perfect sphere, which is completely dry, perfectly flexible, infinitely thin. But cornea is not a perfect structure, and therefore other forces come into act, and therefore the Embed-Fick law has been modified now. So as I've already talked, number of tonometers are available. The NCTs, which are almost there in every OPD, they're used for mass screening and they do not require anesthesia, fluorescence, they don't cause any injury to the cornea, but their accuracy is good enough within the normal range of the IOP. Very low IOP or very high IOP, their accuracy is not that much. Two tonometers that we have here is Corvus ST and Ocular Response Analyzer. These give us the corneal biomechanics parameters, that is corneal hysteresis, and they also give us the corneal compensated or these biomechanics compensated IOP. And therefore, they are not affected by the corneal biomechanics such as the Goldman applanation tonometer. So let's dive deeper into the inaccuracies or the errors associated with the Goldman tonometer. Instrument-related errors can be there. The first is the calibration error. It's very important to calibrate the instrument at least monthly in the heavy OPDs. According to Haag Street, if there is a calibration error more than 0.5 mmHg, the instrument should be returned. But that results in the logistics errors. So what we can do is, the most common cause for these calibration error is lubrication. So what we can do is we can open the instrument, we can lubricate the joints, and we can use the compressed air to clean the instrument. If there is inadequate illumination, it will also lead to the decreased fluorescence and underestimation of the IOP. Another thing is wettability. Wettability of the applanation probe. What happens that corneal tear film is having a capillary attraction force. So if the probe is wettable, that attraction between the tear film and the probe increases. So it's pulling the AT towards it, and there is underestimation of IOP. Patient-related errors. An anxious patient will squeeze the eyelids. It will lead to overestimation. If the patient moves the head back, Myers will be small, overestimation. If you push the slit lamp too much into the cornea, the Myers will become bigger, and that will also actually lead to the underestimation. Increase in IOP can occur due to blepharospasm, Valsalva maneuver, ciliary muscle contraction, or lid retraction. So what kind of Myers do we want? We want, as you can see on the first one, we want the inner edge of the Myers to actually touch, and the end point is when they are pulsating. All the rest of it, thicker Myers, thin Myers, or all this you can see here, we need to correct it. That means the IOP is not measured correctly. Tonometer eye contact. If there is a prolonged duration of the contact with the eye of the tonometer, it leads to decreased IOP measurement. If repeated IOP measurement if we take, that also leads to reduced IOP. So studies say it's better to go for alternate testing. That is, you take it in one eye, then in the other. Observer errors can be there, but inter-observer repeatability is not that much in GAT. If there is increased rigidity, it can lead to high IOP reading. If there's decreased rigidity, such as in myopia, vitrectomized eyes, in those there could be low IOP readings. Now, if we are taking all these, if we are overestimating the IOP or we are underestimating the IOP, that can actually lead to the misdiagnosis in glaucoma, maybe a ocular hypertension or maybe normal tension glaucoma. So that's why we need to be very careful. So another is that we need fluorescent to take IOP on the applanation tonometer. So thick Myers can be there, which will lead to falsely high IOP, which could be there because if there's excessive fluorescence or if there's excessive tears, or if ever the probe touches the lids or the lashes. Thin Myers can be there, insufficient fluorescence, insufficient volume of tears, and quenching. Quenching is when the fluorescence loses its fluorescence because of the in the acidic solutions, and that occurs when we use proparacaine. In many places, what happens is that we use the fluorescent strip and we wet it with paracaine. Now that can actually lead to the loss of fluorescence of the strip. So what exact we want is the width of the meniscus that should be 1/10 the diameter of the flattened area. Then there are cornea-related errors such as regular astigmatism. So we have to take into account when the astigmatism is more than 4 diopter. For every 1 mm Hg of 4 diopter of cylinder, with the rule astigmatism will underestimate IOP and against the rule will overestimate. So what we can do is we can rotate the white mark on the AT towards the minus cylinder. Another thing we can do is we can take the IOP in the vertical as well as in the horizontal direction, and then average it. So what happens is when this astigmatism is there, the Myers, they are elliptical and not circular. So when you average it or when you take it in the 43-degree axis, they become circular. It's difficult to take the IOP in irregular astigmatism. Corneal edema will lead to, corneal edema will actually lead to the underestimation of the IOP, no matter what kind of corneal edema, stromal edema, microcystic edema. CCT is very important. Thin cornea, underestimation; thick cornea, overestimation. And GAT is highly affected by CCT. Therefore, it is important that we take a corneal compensated GAT reading. So, and another important thing, relationship between CCT and GAT is non-linear. So all the numerical values or tables that we have, they're not completely accurate. We just need to know that if there's a thicker CCT, IOP can be underestimated. And if there is a, thinner CCT, it will be underestimated, thicker CCT, overestimated. Definitely corneal biomechanics affect GAT. It does not affect DCT, ORA, and Corvus ST. So those tonometers are good in those cases. So I'll just briefly tell about some special circumstances. Post-refractive surgery, there's a decrease in CH, CRF, CCT, so there's underestimation of the IOP. And in those cases, DCT, Corvus ST is more reliable. Shipper has also told us one method in studies where you can take the IOP in the periphery of the cornea, in the non-ablated zone. But now the ablation zones are increasing. They are increasing for reducing the nighttime glare and halo. So we do not have that 3.05 mm area in the periphery to take the AT. So decreased IOP measurement following corneal refractive surgery makes the detection of glaucoma in these cases difficult. Post PK, there is alteration in corneal thickness, astigmatism, there's irregular corneal surface. So that can affect the GAT readings, especially when there are sutures. Sometimes Myers are not properly formed. So there are other tonometers available, such as DCT, Tonopen, and iCare, but Goldman is still considered as the gold standard. Post-vitrectomy in the gas-filled eyes, what happens is most of the tonometers, they will underestimate, especially if the compressible gases are there. If it is a non-compressible gas, then you will get the IOP, which is actually there with the tonometer. Again, Goldman is used post-vitrectomy as well as post-silicon eyes. Keratoconus hugely alters the biomechanics. There's thinning of the cornea, decrease in the biomechanical factors. So DCT, which is the dynamic contour tonometer that uses contour matching, is not affected by biomechanics. That is better. In irregular corneas, we can use McKay-Mark, pneumatic tonometer, DCT. In soft contact lenses, Tonopen, pneumatic tonometer. GAT, first of all, you need to use the fluorescent, which will stain the lens. And with soft contact lenses, it underestimates. With rigid contact lenses, it might give a higher IOP. In K-Pro, digital tonometry works good. In infants and children's, iCare tonometer is used, which can be done with them in the lying position as well. And Perkins handheld tonometer is there. So in conclusion, I would like to say that Goldman tonometer still remains the standard in most of the cases. But what we need to keep in mind is that there are factors which can lead to the errors while measuring the IOP, and therefore we should always keep them in mind for better management of glaucoma. Thank you everyone for listening.
Non-contact and applanation tonometer and the recent rebound tonometer. And one should be well aware of how to do the tonometry and how not to create mistakes. And one thing is important: overstaining, repeating the tonometry again and again is actually will not give you very good results. And whenever you are going to do a gonioscopy, always wait for some time after doing the tonometry. That is important. I'll highlight this. Okay, thank you, Dr. Surbi. Our next speaker is Dr. Sumit Monga. He's a senior neuro-ophthalmologist and pediatric and squint surgeon at Center for Sight, Delhi.
Dr. Swati and respected members of the audience. So, can you just put it on the screen? Yeah. Well, sometimes it really helps to expand your horizon. And in our case, basically what it means is to segregate the neuro-ophthalmic cases from the glaucomatous cases. So what I'll try to do is I'll just try to attempt some clinical scenarios which will probably help us to understand the pertinent points. So let me just present one of a case of a middle-aged male who presented with visual loss in both the eyes. So he had this asymmetric cupping, as you can see, left more than right, and the OCT shows a gross thinning of the RFNL and the ganglion cell thinning. But then this was not correlating with the glaucoma. So what we did was simply do a red-free assessment where you can see now the pallor that was not earlier visible. Now we know that the pallor is more than cupping in this case. So we also correlated this with the visual fields, and you can see a gross advanced visual field effect somehow following the scotomas being more denser in the bitemporal quadrant, and the neuroimaging revealed the inevitable. So this gentleman had a large pituitary macroadenoma, and after the surgical removal his fields improved. So the learning points are that we have to actually sometimes specifically rule out the dispallor by the red-free light or use an OCT correlation to really rule that out. And the red flags in this particular case was pallor more than cupping. The central vision was lost early, and there was a disparate retinal nerve fiber layer and GCC loss on OCT, and the vertical meridian. The field defects were respecting the vertical meridian. Similarly, we had another case with decent vision in both the eyes, but on the fields we had this supranasal quadrantic loss in the right eye, and the disc is also correlating. It has cupping, and then OCT, and the wedge-shaped retinal nerve fiber layer defect. So everything fits in. But when you dilate this patient well and see in a red-free light, you would notice that this patient actually had an infratemporal BRVO, which was responsible for this kind of loss, which can easily be related to you can make misdiagnosis of glaucoma if you really don't dilate well. So the learning is that you have to actually have a dilated comprehensive retinal examination before labeling it as glaucoma. And another case which I saw almost a decade ago, where a middle-aged female had progressive loss of vision in both eyes. She had in fact become one-eyed, and she had this dispallor more than cupping in both the eyes. And she was just moving around with this CT scan saying that everything is okay in the brain. And when we just saw this lady, she had an advanced visual field defect, and luckily she was carrying a field which was done 4 years ago. And what happened to the right eye field? Obviously, the vision was so poor in the left eye, we didn't really had that. So what basically you're saying is that you have advanced field defect in the right eye, and when you actually see this, supratemporal field defect in the left eye, in the right eye, sorry. So what you can actually correlate is that probably, she can have a absolute visual field defect in one eye, and there could be a junctional scotoma in the other eye, which can be due to a prechiasmal lesion. So if you see, this is the chiasmal area. So if there is a lesion which is pressing on the junction of the optic nerve and the chiasmal area, the whole optic nerve of that side, along with the looping fibers of the von Willebrand can be get affected, and this can lead to this kind of picture which this lady had. And because these things are not picked up in the CT scan, we did an MRI, and guess what? She had a meningioma both in the brain and the optic nerve, and luckily, whatever residual vision she had in the left eye could be salvaged, after proper surgery. So, correct interpretation of the visual field defects and the correct choice of neuroimaging is must, where things are not explained, although you may have a progressive optic neuropathy. So just would highlight your attention to the next set of cases. This is an elderly gentleman with the diagnosed case of arthritic AION, and see, when he heals in about 3-4 months, he actually gets a cupping, which is not unknown in arthritic AION. Another gentleman who has a cupping in the involved eye, which is much more than what he actually has in the fellow eye also. So there's no parapapillary atrophy you can see. So the absence of pallor in glaucoma cases, the neuroretinal rim being healthy, and the probably peripapillary changes probably in a glaucoma cases are one of the distinguishing factors which can lead you more towards glaucoma. Another case who had a existing keratoconus, but he also had a hyperemic papillitis in the left eye, which led to acute decrease in vision. Notice that he had an altitudinal field defect, but on investigation we diagnosed it as a atypical MOG-related optic neuritis. And when this patient healed after the appropriate treatment in about 3-4 months, this patient actually had cupping in the involved eye. And similar cupping was also pre-existing in the other eye, indicating that he had a similar process going on in the other eye. So both these cupping related changes actually happened due to the optic neuritis which this patient had. So what's happening here? Neuroophthalmic disease leading to optic disc cupping, which has been traditionally a hallmark of the glaucoma. So can the changes that have been implicated in glaucoma explain the neuroophthalmic disease cupping also? Yes, probably. The tissue atrophy of the prelamellar regions, which can occur in both the pathologies, can lead to a lot of volume loss in the optic nerve, which can again contribute to the cupping. Then we can have a backward bowing of the lamina cribrosa, which is a known fat in the glaucoma, and similar thing can happen in the retrolamellar tissue loss in the neuroophthalmic disease, especially when there is an infarction of the optic nerve. And then you have a destruction or weakening of the lamina cribrosa as such, which can occur in both the pathologies. Then presenting another case where the lady had this kind of almost an altitudinal defect and bilateral optic atrophy in both the eyes. Actually, on detailed testing, we discovered that right eye just had a pseudo dyspallor, which was not really having an OCT correlation also. It was just the left eye we had this ganglion cell loss and the inferior thinning of the retinal nerve fiber layers. And this lady actually has documented the clinical picture almost 3 years back, 4 years back, where we had a lesser cupping, but the pallor was there in the left eye too. Now, if we just see the visual fields that this lady had, so we can classically see a supro nasal field effect in the left eye nasal step, which was gradually progressing over the next 4 years. And similar thing was correlating with the inferior retinal thinning in the left eye. The retinal nerve fibers were relating. So this is classical glaucoma. But how do you explain the pallor? Now, this lady was a professional hockey player and she had suffered trauma 30 years ago. And that's what probably led to the optic traumatic outward neuropathy, and the glaucoma came later. So this was a combination, which was going on. Another lady where, we have this optic disc cupping in both the eyes, cupping more than pallor, and she had gross disparate thinning on the GCC and the RFNL, which was not really fitting in glaucoma diagnosis. But the clue came from the past family history records. The brother was an index case of Leber's hereditary optic neuropathy. Mother was a documented carrier, and all her siblings had, documented LH1 mutation. And this is what was leading to the gross GCC thinning. But when we actually saw on the visual field, she had a classical arcuate scotoma. And if we compare to the fields that she had some time back, in fact, the arcuate scotoma had actually increased, indicating that, okay, she had this LH1 related optic neuropathy, but there was a subsequent glaucoma also which was coming up in this lady. So again, a coexistence of a neuroophthalmic disease along with the glaucoma. Another case where we have classical findings of glaucoma, as Dr. Pandav just highlighted, the loss of the neuroretinal tissue, as you can see in the right eye, classical notching and asymmetric disc asymmetry. But again, the RFNL and the GCC were such grossly thinned out, and if you carefully notice, there are some clues here. The thinning is more on the nasal and temporal sides rather than on the poles, which are more commonly seen in glaucoma. So this, along with the visual fields, although the visual fields were quite correlating with what we had in the OCT, so this prompted us to actually do a neuroimaging, and we discovered that this patient actually had a compressive component from a tuberculum sella meningioma also along with glaucoma. So that was again a coexistence that we had. So apart from these, also be aware of the optic nerve pathologies, which are developmental anomalies of the optic disc. A lot of has been described before. Either this can actually, cause confusion because of the disc appearance or because of the accompanying visual field defects which may be there. To summarize, we can have the diagnostic dilemma in form of discs which are suspicious or a visual field, defect. So both the structural and functional defects. So the red flags which require neuroimaging would be an early and disproportionate loss of central vision, along with color vision, dyspallor more than cupping, absence of notching, presence of RAPD, acute or subacute vision loss, and particularly young patient, visual fields respecting the vertical meridians, binocular, specifically the pattern like hemianopia, rather than the nerve fiber layer defects seen in the glaucoma. Then also optic disc is common but not an exclusive hallmark of glaucoma. Glaucoma and neuroophthalmic disease can simultaneously coexist, and beware of the developmental anomalies of the optic disc which can simulate glaucoma. In the end, glaucoma is not a spot diagnosis. It's a culmination of both the historical and the clinical findings, and requires a meticulous approach. Thank you very much.
Thank you, Dr. Sumit, I think, for elaborate and excellent presentation. I think next is Dr. Swati. But before Dr. Swati, I think, takes the stage, just a quick question, basically. There are a lot of neuro-ophthalmological conditions. They can be confused with glaucoma. Now, the patient is coming to you. I mean, she doesn't have all these investigations done. So the question is, I mean, when do you clinically, would refer a patient to a neurological or neuro-ophthalmic evaluation? Because these patients are coming to as glaucoma patient. Now you see something in the clinical examination, and then you'll say that, okay, this patient needs neurological opinion. I think, to my mind, that would be a very important question to be asked and answered. So what are the clues, basically, that you take, for that? Yeah.
Thank you, sir. As I just mentioned, basically, we have some clinical parameters. Like, first of all, starting with, suppose the patient is a little young with no specific family history, but these are obviously, this can be blurred. There are a lot of gray zones. And the patient has a central vision loss along with color vision loss, which is happening early in the course of disease. It can occur in glaucoma also, but these are, late onset parameters. And apart from that, we do have disparate imaging, imaging parameters on OCT or visual field loss, which is respecting the vertical meridian rather than the horizontal meridian. So basically, a combination of a good clinical examination along with, a good history, and always listen to the patient, whether it was an acute loss or, a chronic loss. Glaucoma is a slow disease. So all these parameters which we already know. So before really trying to read the reports, I would say, first actually concentrate on the clinical aspects. What exactly has happened? Is it a symmetrical? Is it a asymmetrical? What kind of clinical findings they have. So it's a combination of all that, which ultimately probably leads us.
Thank you. Thank you, Dr. Smith. I think, and we move on to the next topic, Dr. Swati, once again, and we'll take up some of these questions, if we have time in the end. Dr. Swati, please.
So, gonioscopy, a simple test done properly, can change the entire management plan. So, gonioscopy, we know, is the technique to visualize the angle of the anterior chamber, which cannot be seen otherwise with the naked eye. Pointer. The reason is total internal reflection, which does not allow the light rays to pass out from the coming from the angle of the anterior chamber. So to avoid this internal reflection, we need the gonioscopy lenses in the form of either a direct gonio lens, which is a convex lens, or mirrored gonio prisms like Goldman or Posner and Sussman lenses. So just a brief overview of the anatomy of the anterior chamber angle. I think everybody knows that to begin from anterior to posterior, there is this Schwalbe's line, which is the termination of the Descemet's membrane, and the non-pigmented trabecular meshwork, then followed by the pigmented meshwork, and which is the functional part of the trabecular meshwork, and then there is a scleral spur, the thick, dense white tissue, and finally the ciliary body band and the iris, peripheral iris. So this is a open angle, and gonioscopy is considered essential in all the patients who are glaucoma suspects, in the patients who have shallow anterior chambers before dilating, in trauma and uveitis patients, and patients with the any disease which can cause neovascularization, and like retinal vein occlusion, ocular ischemic syndrome, PDR, etc. And before planning a mixed procedure, as you all know that recently there is sudden increase in the number of mixed procedure, but before doing a mixed procedure, one should be aware of the normal anatomy of the angle. So this is basically I just discussed this is what it should be, and the reality is that in a study in US it was seen that in Medicare beneficiaries who underwent glaucoma surgery in the preceding 4 to 5 years time, only 49% of them had a gonioscopy test done, and this included even the angle closure glaucoma patients. So this is the reality, and I would say that gonioscopy is an underutilized test in glaucoma, and it can offer much more than simply classifying the type of glaucoma and the grade of angle closure. So, but there are some problems in gonioscopy. Maybe that's why people don't want to do gonioscopy. What are these problems? Using an incorrect lens, incorrect technique, a learning curve for the examiner, a poor documentation, inter-observer variation, and being a contact method, many of the patients, they do not want to get it done, and many of the doctors, they do not want to do it. So, and it is difficult, and photography is impractical. There are other methods that are available for anterior segment imaging, such as this AIOCT. You can see it can tell you about a narrow or closed angle, but it does not show the structures beyond the iris, and indentation is not possible. Secondly, we have this UBM. UBM can show you behind the iris, but it is not available everywhere, and you need an expert to do the UBM test. So misdiagnosing a patient for non-availability of expensive machines is not justified actually, and one should always do gonioscopy. What are the common problems that one faces with gonioscopy? Using an incorrect lens. So maybe it's my own opinion, but I think the beginners should not start with this lens, because this Goldman type single mirror or double mirror gonio lens, this is the ideal lens to give you the best view of the angle, and after that they should proceed to do this 4 mirror gonio lens, because it needs too much of practice. And the reason is that when you are doing a 4 mirror gonioscopy for a beginner who is not experienced, this is what the view that he can get, and you get lots of corneal folds because they do not know how much of pressure has to be applied, and the hand has to be stabilized first. So it is always better to first identify the landmarks. For the students, I'm saying, so first identify the landmarks and then proceed to the next level, that is the 4 mirror gonioscopy, which has to be learned. Incorrect method: when there is too much of light in the examination room, there is too much of illumination from the slit lamp, the beam is too large and crossing the pupil, which can constrict the pupil and artificially open the angle, a lens that is tilted, not clean, or there are bubbles in the coupling fluid, too much of fluorescein, and inadvertent indentation before a normal examination. So the idea is to focus on the angle. So beam should be small and low illumination, and on the angle and not on the pupil. Then excessive fluorescein can smudge your entire tear film, and although you can see here this is a patient post-trauma and lots of pigment is there, but fluorescein does not give you the best view. So always avoid doing a tonometry before a gonioscopy. Then air bubbles can also obscure the view. So as I said, avoid doing gonioscopy immediately after doing an indentation tonometry, and the reason is that it can open the angle artificially if you're applying too much of pressure with the tonometer also. Then second thing is using the corneal bridge technique for identification of the angle structures. There are certain cases when the angle is hypopigmented, the TM is hypopigmented, and there may be excessive pigment also anterior to the Schwalbe's line, and in patients who have narrow angles. So in such cases, it is always good to make a corneal bridge, this narrow slit beam with oblique illumination, and this anterior and posterior parts of the beam, they meet at the make a wedge here. This point is the Schwalbe's line. So you can identify the structures behind the Schwalbe's line by making this corneal wedge. Then the indentation gonioscopy, all of us know that these indirect 4 mirror gonio lenses with a small corneal diameter, they can be used to put pressure on the central cornea, and this pressure will force the aqueous into the periphery and open an angle which was closed only by apposition, and angle that is closed by synechiae formation, this will not open on indentation. So Do not miss the iris contour. One should always look at the contour of the iris. See, this is a patient who has a convex iris. It is seen, I mean, normal patients do have slightly convex iris, but this is too much and is seen in angle closure glaucoma. Then extremely concave iris you see in cases of PDS, pigment dispersion syndrome, or sometimes when the lens is not stable and zonules are very lax. And a straight contour here. Then what is causing pigment dispersion? With the help of gonioscopy, we can find out actually. This is a case of classic pigment dispersion syndrome. You can see all the findings here in the cornea. The Krukenberg spindle is present and there is dense homogeneous pigmentation all over and in the 360 degrees of angle, more so in the inferior part, and concave iris and Krukenberg spindle. So this is the second case is this is an iatrogenic pigment dispersion or secondary pigment dispersion with secondary glaucoma. So this patient had iris transillumination defects in the periphery, and she had a cataract surgery done with a PCR, and a single piece IOL was placed in the sulcus, and this haptic is rubbing against the iris and causing the dispersion of pigment here. In fact, you can see the haptic over there in the sulcus with the help of a gonio lens also, if the pupil is not dilating very much. Then this is another case of pigment dispersion, but this is not pigment dispersion syndrome. Here the patient had herpetic keratouveitis with extensive pigment loss from the iris. And you can see this extensive transillumination defects are present, and this is the type of pigment we get in the angle in these patients also. But the iris contour is not concave, unlike the typical pigment dispersion. So there are other cases like when the iris has been in contact with the trabecular meshwork or peripheral cornea, you can get this type of picture after the resolution of acute angle closure attack. In this patient, a PI had been done, and this is the picture after the attack was resolved. So then one can locate a foreign body in the angle. This is some plastic piece that I found accidentally during gonioscopy. This was lying inert in the angle, but it was there. And then there is a thread after a fiber lying in the angle after a cataract surgery in this patient, which was causing irritation and recurrent inflammation. So now look at this patient. Here this patient came for a cataract surgery, but I found this mass over here on the cornea, and you can see there is superiorly there is iridocorneal adhesion. There is no AC in the superior part, but when I got the UBM done, you can see there is this fleshy tissue over here, but it does not give you any details of the structure. So I did a gonioscopy, and here you can see I get the entire anatomy of the lesion here, and the pigment epithelium coming from the behind the iris extending towards the cornea anteriorly, and this is what was coming on the cornea anteriorly. So you can even see the ciliary processes here with gonioscopy. This patient, we did oculoplastic surgeon did a biopsy, and we did not find anything abnormal here. So we went ahead with the cataract surgery, and it was like patient is doing fine. So there can be more than one mechanisms of glaucoma. Like in this case, there was pigment dispersion in the cornea as well as in the angle, but then in one eye there was angle recession also. So this patient gave a history of trauma in this left eye in childhood. Then sometimes for academic purpose and for documentation, you can have a better view with the gonioscopy than with any of these ASOCT or other pictures. This is a case of anterior segment dysgenesis. Then this elderly lady came with the pressures of 28 to 40 millimeters, shallow AC and closed angles. On gonioscopy only I found some cystic lesions here in the behind the iris from the ciliary body zone. When the lens is too high, you can visualize the structures of the ciliary processes and all. So these cystic lesions, we thought that angle closure was because of these cystic lesions, but actually on UBM we found that they were in the pars plana region. So the patient was having pars plana cysts in both the eyes, and they were not extending to the pars plicata. And so we went ahead and did a cataract surgery along with a glaucoma surgery in this patient. Now, checking for the patency of this trabeculectomy fistula, you can always do with the gonioscopy method. And then plateau iris with the indentation gonioscopy, one can see this double hump sign because of the prominent peripheral ciliary processes. This sine wave or S-shaped or a double hump sign can be seen in plateau iris syndrome, where the angle doesn't open even after a PI. So this is a patient, 45-year-old, unilateral glaucoma on combination drop but stopped for a month, and the pressure is 20 by 30. Disc is right eye normal, but left eye is 0.75 is to 1, and a wide inferior notch and RNFLD was present. So you see this patient has the right eye is normal, but left eye has a dense superior arcuate scotoma close to fixation. Why was this defect happening in this patient? Why was he having this unilateral glaucoma? So OCT also showed similar picture. A field test is showing a typical RNFL defect over here in the left eye, a wedge-shaped defect. And when I did gonioscopy, I found my answer. The patient was having angle recession, and he had a history of trauma a few years back. So similarly, we can visualize iris cysts and all. This is a pigment epithelial cyst, which could be seen by gonioscopy under dilation. And there is a myth that pseudophakic patients, they do not need gonioscopy. Actually, any glaucoma in patients having pseudophakia, one must do gonioscopy, but not in immediate post-operative period. So this patient, first one, he had a pseudophakic pupillary block. You can see the iris Bombay here, and PI was done over here. Then the second patient had aqueous misdirection, and this was after 6-7 years of cataract surgery. And this is a secondary angle closure, not a pupillary block mechanism. So similarly, I mean, there are many other things you can diagnose with gonioscopy. This is a patient with acute uveitis, and we found a nodule in the angle. This is actually a patient of sarcoidosis, and we call it as Berlin's nodule, I think. So then volcano iris and configuration. You can sometimes visualize the ciliary processes through the gonioscopy without dilation, and this is a sign of anteriorly placed lens or zonular pathology or anterior subluxation. Then I also use gonioscopy for the diagnosis and assessment of subluxation of lens, especially in the dilated, I mean, we can dilate the patient safely, then you can use it for lens assessment. And also, if you do not have a fundus camera, you can use this gonio lens for optic disc evaluation as well. To summarize, there is no other modality that can replace the gonioscopic visualization. There are no added costs, but you need a good slit lamp and a gonio lens and a compliant patient and a willing and inquisitive examiner. Thank you very much. The next speaker is Dr. Mansi Jory. He'll be speaking on importance of history taking and examination.
Good evening, everyone. I would like to thank AIOC and Dr. Swati ma'am for giving me opportunity for the presentation on this platform. So my topic is, are we still missing something? Role of systemic workup in glaucoma. So as we all know, glaucoma is a multifactorial optic neuropathy that causes a characteristic acquired loss of retinal ganglion cell and atrophy of optic nerve. Number of people suffering from glaucoma in 2013 was estimated to be 64.3 million worldwide and expected to increase up to 76 million in 2020 and 111.8 million by 2040. So here we see how intraocular pressure is the only modifiable risk factor. So we can see here that in spite of a normal IOP, we have a normal tension glaucoma as an entity, and in presence of high IOP, we have ocular hypertension and open angle glaucoma. So the question is, IOP is the only risk factor? We have all seen patients well on their target continuing to progress. Why does it happen? Is our target wrong? Are the patient not compliant enough? Are there other factors, and how do we identify them? So can glaucoma progress when IOP is well controlled? Answer is yes. What else do we evaluate and treat in glaucoma patient? Let us see. So how do we identify those? So obviously any patient who is progressing needs further attention. Look into the compliance in detail. Look for the IOP fluctuations. Look at the cause for the fluctuation. Is it a fluid overload? Could it be a tight collar? Or could it be a periodic breath holding like in some yoga asanas or in some musicians? So the importance of history comes into play. So what else we have to ask in a glaucoma patient? We have to ask for a systemic hypertension. Is it controlled or is it over controlled? We have seen this that in patients who are having their antihypertensive medications at night, they specifically can have a dip in their diastolic blood pressure. Secondly, we have to look for any compromised ocular perfusion like Raynaud's or sleep apnea, hypertension, syncope, or any history of acute blood loss. Then there can be certain medications like systemic, inhaled, and topical steroids which can elevate IOP. There can be neurological symptoms like headache, weakness, dizziness, diplopia, or loss of consciousness. So ocular perfusion pressure. The term ocular perfusion pressure refers to the net pressure gradient causing blood flow to the eye. It is the driving force for the ocular blood flow. It may act as a risk factor or as a progression factor for open angle glaucoma. So ocular perfusion pressure, mathematically it is calculated by 2/3 of the diastolic blood pressure plus half of the difference between the systolic and the diastolic minus the intraocular pressure. So we can see in this equation that diastolic blood pressure has more role in the ocular perfusion pressure as compared to the systolic blood pressure. So this is the flow chart which is depicting that reduced ocular perfusion pressure with the reduced cerebrospinal fluid pressure, biomechanical properties, increased IOP, decrease in the blood flow may cause a primary insult. Along with that, in the presence of the primary insult will further result into the retinal ganglion cell mitochondria mildly affected. Then there may be reduced energy levels at the level of RGCs, which may lead to a secondary insult. And along with that, abnormal neurovascular coupling, along with the abnormal autoregulation, which can cause reduced ocular perfusion pressure. Ultimately, they will lead to the RGC cell death. So what is vascular autoregulation? Why is it so important? So it helps to meet the body need. Vascular tone maintain an appropriate level of hydrostatic pressure, avoiding edema. Regulation of this is maintained by autonomic nervous system, systemic hormones, and local autoregulation. So two types of stimuli, myogenic and metabolic, which can induce a response from local vasculature. Metabolic demand or supply can increase or decrease, which can modify the perceived need of oxygen and nutrients. And the metabolic factors can alter the vascular tone. So the myogenic factors, as the blood flow increases, the smooth muscles of the vessels are stretched. This opens the calcium channels, and with influx of calcium, the muscle contracts and reduces the lumen of the vessels, which reduces the blood flow. So deranged autoregulation, there has been several studies which have shown this autoregulation to be deranged in glaucoma. This can be due to dysfunction of endothelial factors responsible for maintaining the vascular tone. What it does, the impaired autoregulation results in altered oxygen being supplied to the ocular tissue. If reduced, there would be an ischemic change, and increased level can lead to oxidative stress and ultimately cell damage. So let us see a case. A young 35-year male came with a history of sudden fall in vision. On examination, CRVO was diagnosed in one eye and high IOP in both the eyes. He was treated for a CRVO, but his glaucoma was progressing despite on maximum medical therapy, and the IOP remained in low teens. What was the cause? So we further investigated the patient with carotid vertebral and ocular color Doppler. So we got a plaque grade 3 to 4, which was noted in common carotid artery at its bifurcation, with thickened intima was noted in common carotid artery, suggestive of atherosclerotic changes. So ocular and spectral Doppler study is suggestive of occlusion of left ophthalmic and central retinal artery, causing a left-sided ocular ischemia. So reduced blood flow velocity and altered resistivity index can be predictor of glaucoma progression. Color Doppler imaging is good modality of the imaging and the hemodynamic study of the optic nerve vessels. It may help facilitating the understanding of the pathogenesis of glaucoma. So what we may do? Introduce the blood flow measurements into the clinical practice for diagnostic and follow-up glaucoma disease, which could help in the care of patients with glaucoma. Migraine, a very important factor. Patients with migraine have higher IOP, and patients with normal tension glaucoma have higher incidence of migraine. Migraine is vasospastic despite having a neural origin. Vasospasm may be related to endothelium-derived vasoactive factors. Both Raynaud's and migraine are associated with increased endothelin-1 and also the normal tension glaucoma. Cerebrospinal fluid pressure. Retinal ganglion cell damage occur at the level of lamina cribrosa, yet we measure the pressure across the cornea. Patients with open angle glaucoma and NTG have lower cerebrospinal fluid pressure, where patients with the ocular hypertension have higher CSFP than controls. The translaminar pressure difference may be more relevant risk factor than the transcorneal pressure difference. Whether cerebrospinal fluid pressure is or will become easily measured, let alone modifiable, is still questionable. Sleep apnea. So, obstructive sleep apnea, a chronic condition leading to apneic periods with hypoapneas and respiratory arousal, are an emerging risk factor for glaucoma. According to Wisconsin's sleep cohort study, the incidence is found to be 2 to 4%.
We are getting late. Please speed up.
Found to be associated with systemic hypertension, cardiovascular disease, stroke, and abnormal glucose metabolism. So, 10% of OSA have glaucoma, and 50% of the NTGs have OSA. So, Slurgy et al. Has also found the severity of OSA to be correlated with IOP, and metabolic and vascular changes result from the excess CO2 superimposed on endothelial damage due to hypoxia is probably responsible for glaucoma. So, how do we measure it? We have an apnea-hypopnea index, which is used to indicate the severity of sleep apnea. So, OSA is defined when AHI index is more than equal to 5, which leads to decreased blood oxygenation. So, these are the vascular and the mechanical factors. So, very important is the blood viscosity, which is also an important risk factor, which lead to decrease in the blood flow and stasis in the capillaries, which in turn lead to hypoxia. Hypolipidemia, which is another form of increased blood viscosity, which would increase the episcleral venous pressure and blood and result in consequent decrease in the outflow facility. This hemorrhage we have all seen. How is it affecting? And it is considered as a sign of ischemic optic neuropathy in glaucoma. So, diurnal variation, again, it is a very important risk factor for the progression in glaucoma, and AJ's study has proved larger diurnal variation IOP increase the odds of visual field progression in eyes. And similarly, the diabetes mellitus has been equally found to be affecting. Like, firstly, the diabetes would increase the impairment of microvessels and vascular autoregulation, which lead to further injuries, reducing the blood supply. Secondly, it would cause increase in the neuronal injury, and thirdly, it would lead to stimulate the synthesis and accumulation of fibronectin in the trabecular meshwork, which would promote the depletion of trabecular meshwork cells. And as we all know, hypertension is equally correlated with the glaucoma, and several meta-analyses has found systemic hypertension to be increases the risk of POAG. And what are the hypotheses? Reduction in the ocular perfusion pressure below the critical level of autoregulation, structural changes in arterioles, nocturnal dippers, and effects of antihypertensive, especially when taken in the night time. Thyroid disorders, similarly, in case of both hypothyroidism, which causes excessive mucopolysaccharide accumulation in the trabecular meshwork, act as a surfactant, which lead to increase in the IOP as well as aqueous outflow resistance. Similarly, in the Graves' disease, IOP may be raised as a result of contraction of the extraocular muscle against the intraorbital adhesions or orbital congestion due to increased tissue volumes. So what we can alter is ocular perfusion pressure, obstructive sleep apnea, vasospasm causing migrainous headaches, treat systemic hypertension judicially, stabilize diabetes, treat hyperlipidemia, and prevent IOP fluctuation or fluid overload like in breath holding and certain yoga posture. Thank you.
Thank you, Dr. Mansi. Any question from the audience? Yeah. So we are running out of time and the next session has to start. So I must thank Dr. Pandav sir, actually, and thank you all for the session.